I might invite our panel members up today and we will have a chat about what it means to be a GP. So, I would like to invite up Dr Jason Agostino, Yew Choy Cheong, Emily Rushton, Duncan MacKinnon and Mel Dorrington. Marks on. All right, so we have a really diverse panel up here today, many of whom I've had the pleasure of working with, collaborating with, being taught by, and absolute respect to the knowledge that is on here. We're going to have a few questions that I'm going to give them, and then hopefully, because I managed to stay to time, we have a little bit of time at the end to have some questions. So an interactive section is really fun, so write down your questions and make sure that you ask them when we've got time. All right, so first up, I'm actually going to ask each of the panel members to give their 30-second elevator pitch and introduce themselves. So we might start down at the end with Duncan.
Hi, I'm Duncan MacKinnon. I'm a GP anaesthetist in Bega. You might call me a rural generalist. I love what I do. We have 100 acres and I have 4 kids, and it's just a fantastic life.
Presses on. Hey, I'm Jason. I'm a non-Indigenous GP and epidemiologist. I work across policy, research and clinical practice. So my main gig is the Senior Medical Advisor for NACCHO, the National Aboriginal Community Controlled Health Organisation. I work at the ANU with Yadura Walani, which is the National Centre for Aboriginal and Torres Strait Islander Wellbeing. And I do my clinical medicine, and have done for the past 13 years, at Gurani Lamaka, which is an Aboriginal Community Controlled Health Organisation in Gungandji country in Yarrabah, which is an hour outside of Cairns. And I'll stop there.
Okay, I'm Melanie Dorrington. I am the Chief GP and Primary Care Advisor for ACT Health, and I still work 1 day a week clinically in general practice down at Interchange at the moment. I am not an ANU grad, but came down here from internship and have been around here since. And just to quickly cover my diversity of what I have done, I've been a GP clinical editor with Health Pathways, a GP liaison officer in Southern New South Wales LHD, where Duncan was also. I've acted as the GP policy advisor and acted as the director of the academic unit of general practice. I enjoy women's health. I've worked at the Women's Health Service. I've done telehealth in women's health, specialising in abortion care, and I've been a clinical director of that service as well. And I've been on the Shift Pack Council and Women's Health Matters Board. So just for the diversity of things that aren't just clinical, covered a bit.
So that's a hard act to follow. My name's Emily Rushton. I'm a local Canberran and an ANU grad. My primary role is I'm a GP at Chapman Family Medical Practice in Western Creek, but I combine that work with working as a forensic medical officer for Canberra Health Services. So we do largely sexual assault examination and then provide a number of clinical services to ACT policing, including death investigation, management of people in police custody in the watch house, and then a number of forensic services like swabbing offenders and various other things. I also have a role with the RACGP, so I'm the ACT representative on the ACT and New South Wales Faculty Council. I'm the ACT representative on the GP in Training Council. I am no longer a GP in training, so that role is going to be up for grabs if anyone would like it. And I am very humbled to be here today with some very impressive GPs who have trained me through my career, and also my childhood and teenage GP will be here later today. She still looks after my parents very well, Dr Louise Kenyon, who you'll hear from later today.
My name is Yew Choy Cheong. I'm a GP in East Canberra General Practice, which is in Majura Park. I'm a very clinical person, so I do a lot of GP work and also a fair bit of skin cancer medicine. So I transitioned from surgery to GP about 10 years ago. So I managed to bring a lot of those skills and apply in GP. Yeah, so I love my work.
I might start with you then. What made you change from surgical to general practice?
Yeah, surgery has been what I wanted to do since medical student. So, I love going to theaters, try to get into, lots of trainings, plastics, all those. In the end, I got into general surgery. What made me change was, I think, it was in my third year of training. It was a quieter year. I think finished all the exams and everything. But that's when I started, thinking. I started having my family at the time, my wife and my kid. And I just couldn't see myself doing that long term. I love surgery. I like doing stuff. I like to be in theater. But unfortunately, everything comes in packages. So that's when I started thinking, GP is a good option because it's a very diverse sort of field. I can do a lot of things. So I can also bring my skill, which I've learned, 3 years, and I use it in GP. So yeah, hence my interest in skin cancer management.
It's always lots of people will have that moment where they think, oh, actually generalism is for me. For me, it was when I'd put in my application for the PEDS registrar job. I was already working in the role, and all of a sudden I was like, oh, actually, I think I really miss adult medicine. So withdrew my application, got a job with sexual health for a year and went into general practice training. What about you, Emily? What made you go into general practice?
When I went to medical school, I wanted to be a forensic pathologist. I'd wanted to do that ever since I was a kid. And I remember being in our first histology lab and looking down the microscope and realising I hated it. And this profound sense of grief that this thing that I'd worked towards since probably being about 12 years old, I was not actually going to be able to do. So I sort of wandered through the rest of medical school, not really sure what I wanted to do, did my internship and residency, just waiting for that aha moment of here's what I want to do. I then had a baby, I followed in Kerrie's footsteps and I worked at the Sexual Health Centre, and for the first time I thought, this is what I want to do, I love this. And in order to get a specialty in sexual health medicine, you had to have a fellowship in something else first, so I decided I would do general practice. So I went into general practice not actually intending to be a GP, and absolutely loved it. So one of my special interest areas, I really enjoy paediatrics, I really enjoy sexual health, and I really enjoy transgender care. And being able to combine all of those three things in one job. And then I learnt that I actually really love diabetes management, I really love cardiovascular disease, and being able to do a mix of those things every day was just wonderful. Then this forensics role came up, part of which involved death investigation. And so that combination scratched all of the itches I had about medicine, and I ended up very happy.
Fantastic. And look, I highly recommend a year in sexual health. It's a great... sometimes the jump from doing ward work in the hospital out into general practice feels like it's really big, to go from being, essentially following people around to being the person responsible. And a year in sexual health actually gives you a really great protected clinical year where your scope of practice is reasonably small and manageable. And then if you're getting to the end of it and you're starting to think, no, I want to do more, then general practice is definitely the place for you. But fantastic for, you look after really complex patients. The next question I really want to ask about is those subspecialties. So I might start with you, Mel. When it comes to sort of getting the skills and experience you need to subspecialise in things like women's health, what kind of things would you recommend?
So I think anything that you are interested in, follow the direction of that passion, that area of interest, which you can hear is what has happened here, and I'm pretty sure these guys would be saying the same thing. So, for example, for women's health for me, which was always something that I was interested in our registrar year, our first year registrar year, we got to do the first part of the Family Planning Australia, or the what's it called? The Certificate of Sexual and Family Health? Yeah. I've already forgotten what it's called. And so I continued to pursue that and completed that and got to make connections with Sexual Health and Family Planning ACT, which I found quite helpful. I then continued along that wherever I could. So implant-on insertion is something that pretty much every GP does. But I guess whenever I was doing my own learning, it was what I did a lot of my own learning in, because it is self-directed. And so you do what you're interested in. You identify your need areas as well, and you need to cover those, because otherwise you'd feel like you're not doing your job properly. But, you know, so I got in and I did my IUD insertion training, which isn't that easy to get to, but I managed to fit that in around having my second child. It was timed really well. I could do my supervised insertions before I went back to work after having him. So it's looking for those opportunities and looking for the people to connect with that are already doing it and seeing how they got there. So it's not an area that I've got a lot of formal qualifications in, apart from the little bits along the way, but you know, picking up the stuff around it. So family and domestic violence training, I've done quite a bit of that because that really impacts women's health. And then abortion care, which obviously Kerrie mentioned before, we've got our little local community of practice. And that's certainly something that I'm very passionate about. And I push that to the extent that I'm also part of a group of GPs in Canberra called Deep End GPs, so GPs working in the deep end, so patients that are more vulnerable are the patients in the deep end. And we had the Legislative Assembly inquiry into abortion and reproductive health care in 4 years ago, I think that was now. Anyway, it was a little while ago. No, it's probably only, anyway, it doesn't matter. I felt concerned writing something about it simply with my own name on it. I felt like that was potentially putting my head out there a bit far, where I know that colleagues have been targeted negatively because of their provision of abortion care. So I wrote a document with the support of my colleagues in the Deep End GPs, which went to the Legislative Assembly inquiry, and one of my other colleagues and I went and actually spoke at the hearing for that, and there were no other clinicians from general practice where abortion care should be happening there, because there's no training around it. So it's finding the gaps, finding what you want to do, which may not be a gap, it doesn't matter, and then pursuing it. And it will take you somewhere, and you'll find opportunities like what Emily said. Yeah. So sometimes formal, sometimes not.
Yeah. Jason, you've done some incredible work in Indigenous health over the years. What's your path look like?
Yeah, so there's this Dolly Parton quote, anyway, which is, whatever I've done in my life, good or bad, it seemed like the thing to do at the time. And so I've it seems sort of frivolous, but I guess I've had the fortune to be able to follow opportunities as they change and as my interests have changed over time. So I've worked pretty much exclusively in the bush, and I was in my PGY 3-year, Tamworth Hospital, where I'd done my junior stuff, created this paediatric role for me, which was pretty nice of them. And PEDS in Tamworth is a huge amount Aboriginal and Torres Strait Islander kids, even though they'd be much less than 10% of the population. It was probably 50% of the ward work. And so I guess that piqued my interest. And during that year, they created an outpatients clinic for me, and I realised that was the bit that I liked. I liked the outpatients clinic. I didn't like the acute stuff. I didn't like NICU and stuff. And that's how I realised that general practice was for me. And initially the focus was on kids medicine. And so I did advanced rural skills training in paediatrics, and that involved flying around Cape York and the Torres Strait for 2 years doing kids clinics. And so at the end of that, I needed to pick a community to work for, and place where I work, Yarrabah, seemed like it was the most ripped off in terms of doctors. They didn't have any registrars. They had a community of 3,500. And so anyway, I knew how the system worked by then. And so I said, oh, hey, there's this thing, the government pays my salary, you get to keep my Medicare. This seems pretty cool. And so I guess it's a bit about what Mel was talking about. Like, I've done all my formal stuff in PEDS. I did, Diploma of Child Health, that's my advanced rural skill is. But because the people that I was caring for were Aboriginal and Torres Strait Islander people a lot of the time, that's, I guess, where my expertise is built up, and it's been an informal thing about the environments that I'm in. So once I got to Yarrabah and I got within a community-controlled health organisation, and I sort of saw what it's like to work at this place that has a really ambitious view of how they can impact on healthcare, I was really inspired by them. And I sort of consciously or unconsciously decided that's where I wanted to dedicate my work, both clinically and now sort of in a policy and research space as well. So Yeah, it's a bit weird. Like, it's funny to say I'm an expert in Aboriginal and Torres Strait Islander health because I've never studied anything, I don't think. Maybe I did, I don't know. But it's the places that I've been and the experiences that I've had that have built that sort of career.
Yeah, sorry to break it to you, but you are an expert in First Nations health. Duncan, you've got a really interesting job because you've got the GP anaesthetist role. I think, especially in rural communities, GP obs, GP anaesthetics is absolutely critical. What does that pathway look like?
Well, when I did it, there wasn't a pathway because I trained last century. So it wasn't that long ago, but it was a long time. And so I had to make my own pathway. RSCGP had some obstetric training, but not very much else. And every term I did at hospital, I absolutely loved. But the one thing I was really scared of was critical care. And that just frightened me immensely. So I did a year as an intensive care registrar in Wollongong Hospital, and I mastered that. And when I did that, I was introduced to anaesthetics, and unfortunately at the time, to do more anaesthetic training, I would have to specialise, and I said, I thought, I don't want to do that because I love everything. So I went to the UK, and I went to the UK and I spent 6 years there, and I did 3 years of anaesthetics and 3 years of general practice. Because I wanted to be a rural generalist, I wanted to be a rural GP delivering those services. I wanted to be a real doctor where I just didn't know about obstetrics, but I knew about obstetrics and paediatrics and chronic disease, but I also liked that critical care aspect. And so that's what I did. And then we came back from the UK and we drove around Australia looking for sustainable rural general practice where I could do good anaesthetics. And there were about 4 or 5 places that I could continue to practice that level of expertise where we wouldn't lose services to a bigger centre. So if you're too close to a bigger centre, you know, you kind of die. If you don't grow, you die in the country towns. And so that's why we ended up in Bega doing what I do.
And he's an incredible educator. It was Duncan, I think when I was a registrar, taught us in one of our small group sessions around the principles of pain management and deprescribing of opioids, and I still use the principles that he taught me every single day in my clinic and have very few patients on high dose opioids as a result. So thank you. We're going to do the money talk. And I might put this one to Emily first because I think she's the person who's made the jump most recently. There is a perception of lower income in GPs and a big one about the loss of entitlements in training, which is really important. When you go hospital into general practice, how did you address some of the challenges around this?
When I went from hospital-based medicine to general practice, I went from working part-time to full-time. So I'd had my first baby, I'd been working 3 or 2.5 days a week at the sexual health centre. Then when I started GP training, I did it full-time so that I could be eligible to do my exams as soon as possible. So I actually didn't have a drop in income, but it was because I increased my hours. The reason there's a perception around drop in income is because the award or the agreement that you're employed under as a GP registrar sets a base salary you have to be paid each term. But the fine print of the award is you get the base salary or a percentage of your billings, and it's whichever is higher of the two. And from my second term of general practice, the percentage of billings was always higher than the base salary, and I actually ended up making a comparable amount to, say, my best friend who stayed in the hospital system as a radiology registrar. Now, doctors who are doing a lot of overtime and on-call work and working nights in the hospital, because of the penalty rates, they will earn more than a GP registrar. But for me, the working, more or less 9 to 5 during the week, the occasional Saturday once a month, but no night work. You know, I could take time off to be there for my kids when they needed it, more than made up for that little gap in earnings. And I think the flexibility of a general practice career gets left out of that conversation a little bit. So yes, I probably don't make as much as the cardiologist down the road. However, I also don't have to be on call overnight and go in and cardiovert someone at 2 a.m. So
I do sometimes get up really early and go and see my palliative patients. So, yeah, and this comes down to you get to choose what your career looks like and where your boundaries are. And your boundaries can be different at different points in your life. So you can work more hours and then work fewer hours while your kids are little, and then when they're in school you might choose to work more hours again, and then when they turn 14 you might just take a year off because 14-year-old kids are really hard. But that's the flexibility. I think like you, I did my training in an incredible practice, and I was on a comparable income to what I would have done if I'd stayed in the hospital right from term one. And this is about, talk to the practices, but don't just chase the money, also chase the education. So some clinics are known for having really, really high standards of education and time that the doctors are dedicating to making sure that you have everything you need, not just to pass your exams, because that's a hurdle, but to actually make sure that you're clinically really safe. So look at the culture and talk to people about what the culture of the different clinics you're looking at is like, because they're not all the same. I wish they were. We try and get them to all be the same, but they're not all the same. You've all had really, really successful careers. I know you feel like you're at the start of it, Emily, but you're already like kicking butt. I might start with you. So how do you balance the workload, the personal commitments, hobbies, families? How do you make sure you look after yourself?
Yeah, that's a good question. So that's why I chose GP, I guess. Yeah, I think flexibility is the key. So you're so flexible that you can do as much as you like, or you can just stick to standard hours. So I make sure that I work my normal hours, and I usually have I work 4.5 days a week. So I have a half day Wednesday off. I'll spend my time with my family. I'll have lunch with my wife, and then we're gonna pick the kids up after that, after school. And I managed to do a lot of things that I wasn't able to do when I was in surgical training. So to get back into music, I play the guitar, go back into sports, so badminton. So I just finished this morning. So yeah, so there are so many things that you can do. I don't have to carry an on-call phone and and worry about getting interrupted. And during my dinner with my family, I can just finish work, go home, and that's my time with my family, kids, and my own time. So yeah, so that's.
What do you do for fun, Mel?
It's a very good question. I've only just gone back to full-time work in this last year after I got through my first year of GP training, where I missed the last day of that rotation because my baby came 4 weeks early. So yes, this last year's been my first year back full-time. I have realised that I wasn't doing great self-care, and that the advice I was giving my patients of just you need to fit in a bit of exercise. You just plan it in your day. I've decided that I need to just start getting up that little bit earlier, and it's not dramatic. I'm getting up at 6:45, and I'm taking the dog for a walk, and I have actually set myself goals. I've realised I need to do that, or I don't do it. So not dramatic again, but I need to get 7,000 steps a day, and I need to do 350 active calories according to my watch. And I'm finding that that's actually getting me going. But I also have things that I do with my kids. So my son and I do, he's 10 and a half, he and some of his friends and their mums and us go hiking and camping. So we'll be doing this again in 2 weeks' time, where it's going to be like 5K hike, camp, and then 5K hike back. And that's sort of nice one-on-one time. My daughter, she likes like concerts and musicals and stuff. So we do that sort of stuff together, and cake decorating. So they're different kids, they like different things. But that individual thing, but it's also supported by the fact that my husband now works 2 days a week.
Yeah, I don't think I've actually worked full-time in general practice other than when I was a registrar. As soon as I finished, I went back to 4 days a week, and I've tried working, across 2 different clinics. I didn't really love it. Went back to just working in one, and the reason that I can do the advocacy work that I do is because I spend most of my Wednesdays, nights and weekends doing it, but that's also a choice. Both Jason and I are runners, so he's a fast runner, I'm a plotter. But Duncan, all the medical students come back from Bega talking about surfing and lifestyle, and is it as good as it sounds?
Yeah, absolutely. Bega's about 20 k's off the coast, but on the coast, 20 k's away, where most doctors live, is the east coast of Australia, and it's a beautiful spot, pristine beaches and national parks. They do enjoy that, and I think it's important for us to ensure that they do have a good time, that they do have quality of life, and that they do make or take advantage of the natural environment where we live. For myself, I ride to work every day and I ride home because I can. We do park run every Saturday. We connect with our communities. And we have mini breaks every 6 weeks. So we'll have a 3-day weekend and we'll go camping. We'll go to the mountains, really. Our last adventure, we had 5 days, and I won't go into it, but we actually got lost in the Blue Mountains and had to spend a night out, unplanned and unprepared and unexpected. And fortunately, we managed to walk out the next morning and met the police rescue squad coming to look for us. So it was an exciting adventure, but I wouldn't recommend it.
You and I can agree on parkrun. I'm not sure if we're going to agree on exciting adventures, but I'm going to stay with you for a sec, Duncan, and just talk a little bit about, you've mentioned it already, but about the scope of practice that you can have as a rural GP.
Yeah, look, it's amazing you can follow your passions, and we might talk about this a bit later, but I suppose my advice, and I'm going to say it now, is follow your heart. So if you are passionate about sexual health, or if you're passionate about, you see an opening, I've developed an interest in disaster health since the 2019-20 bushfires. So I've done a grad cert in disaster health management through James Cook since then. So it just informs you, it makes you a better doctor. But what's really important is that it keeps you keen, it keeps you on the cutting edge. You keep reinventing yourself within your sphere of expertise. Being a VMO anaesthetist at the hospital, I still work 2 days a week there and do 1 night on call. But that keeps me keen, it keeps me good at my general practice. And so partly you have to know yourself, you have to know your own limitations, know what floats your boat, and you balance that with some of the more routine stuff that, other people might find a bit boring. There's never a boring patient. Every single person you come across is an interesting human being. You just got to ask the right questions.
Jason, you do some quite remote work. What's that like?
It's great, I guess. I trained in Newcastle, and I really didn't like being in a tertiary hospital. I didn't like the hierarchy. I didn't like being a wallflower, and medicine really kicked off for me in my final year when I went out to Tamworth and got more responsibility. And I had this sort of theory that the earlier I went to bush, the more responsibility I'd be given, the quicker I'd grow up as a doctor, and the more I'd be able to do. And it sort of did play out. My intern and resident years were really great. And and then, because I was interested in Aboriginal health, those communities with the highest proportion are often remote communities, even though there's lots of Aboriginal and Torres Strait Islander health to be had in the cities. So, I've been able to travel to some of the most beautiful parts of Australia and work with beautiful families. I think everyone, when Duncan said he was worried about critical care as a junior doctor. Like that was my thing going out. And I guess when I was doing that sort of stuff, I just needed to make sure that I was still skilled in critical care when I was going out there. But that's actually not my work. Like, and there was different people there to do it. But I just needed to know that if worse come to worse, I could handle it. But because of it, you know, as long as you're happy to go out there and you realise that you're not often by yourself 100%. There's normally some amazing nursing staff around you and amazing Aboriginal health practitioners and health workers. You have an opportunity to see really different medicine, that stuff you don't see in the cities, and have to think differently about resources, I suppose. Like, if I want to send someone for a CT scan, like, that's a big deal. Yeah, it's sort of a fun clinical, well, not fun, challenging clinical problem. Yeah, and then, but that was at one stage of my life, and now I work in a, still outer regional, it's MM5, if you know your MMMs, but I have the support of an ED next to me, and so now I've de-skilled as a critical care sort of person, but I now get to focus on primary care, and that's where I am in my career now, and general practice allowed me to do both of those things at different times.
I think all of us at some stage have heard the scary story from a doctor in a rural location who's had to manage something. But when you actually listen to the subtext underneath, there's often the person on the phone at the other end. There's the course that they did to get there. So for your entire career, I think it's really important to identify the bits that scare you a little bit and really reflect on where the opportunities are to get those skills. So, you know, if you don't feel that you're strong in obstetrics when you get to the point that you're coming into general practice, it might be that you go and sit in with someone for a while. And I was at a function at Christmas time and got talking to a respiratory physician about the fact that I feel like my spirometry is getting really rusty because I haven't really had to interpret them for a while. And straight away he just said, oh, come and sit in with me for a day and we'll go through them and you can just upskill. So the more you reach out to people and say, hey, I don't know how to do what you do, it's amazing how many people will say, how can I help, and provide you with opportunities. But you've got to have the self-reflection along the way. All right, I'm going to do a run through the group and ask, you get to say one piece of advice for everyone wanting to pursue a career in general practice. So my piece of advice is do it, because it's amazing.
That was short.
Yeah, same. Get some experience in the hospital, do a couple of years. It's always a invaluable experience that you can bring to GP, but then, yeah, go for it. GP is fun.
Don't get distracted by all the commentary in the media at the moment. So day to day in my practice, every patient that I see is grateful for the care that I provide and they're happy to pay for it. It's a very different experience on the ground to what's playing out in the media. Let people like Kerrie fight that fight. But as a GP, you are actually valued by your patients and know your worth.
So think about your why and what do you actually want to get out of medicine? Because you need to keep your passion and your interest, or whatever you do, you'll lose interest in. And I'm just going to do a quick plug for Canberra, because I think what Kerrie's saying, having not really worked anywhere else, but I think the close, I think the close connection of people, like I've known the people, we've not really met particularly before, but you know, there are people in this room that I have known across many jobs for a long time, from Duncan being one of my medical educators, Katrina, who will be here later, I met as an intern doing a GP rotation. It's a close community. You know the people that you're working with. It makes connections easier. So stay in Canberra too.
Yeah, I guess invest in yourself. So, you know, we talk about all the opportunities, but that requires a bit of risk sometimes. I've had to, I've worked jobs that are pretty shitty paid and that are pretty funny spaces for GPs to be in, because I thought that that was important as me as a primary care expert to be in those spaces. Yeah, and so it can be investing by doing courses and whatever, but it might be investing in taking some risks and doing different jobs. And So at the moment, my wife should probably be on the panel. She's pretty rad. She's a GP obstetrician. She's on the board of the Royal Australian College of Obstetricians and Gynecologists as their GP obs rep. And that's an unpaid position that comes at a cost to our family, but we believe that for what she wants to do about women's health, it's the place to be. So yeah, invest in yourself.
I'd just like to second that. I'm a little bit in love with his wife. She's pretty amazing. Sorry, Jason.
She is great.
Yeah, she's much cooler than me.
I would say all of the above, but the thing is you've got to be passionate about what you do and you've got to follow your heart. Do your homework, be careful about the culture of where you may choose to work, because you don't want that to kill your passion. So you do need to look into that, and that doesn't matter whether you're going to do hospital medicine or be a hospital specialist or whatever, but it is particularly true in general practice. Follow your heart.
All right, we've got time to questions on the floor. All right, have we got a roving mic, or am I doing the around? Oh, look at that, lovely. All right, so don't be shy. You have some absolutely incredible people on this stage who are really delighted to be put on the spot and have questions. So, hands up. Please don't make me start picking people out. Yep, okay, great, down here. Just do me a favour, just introduce yourself.
Hi, my name is Millie. I'm a first-year medical student at ANU, just finishing undergrad and my honours here. But I also have a special interest in policy. So my question to you is, what are some specific policies that you want to see implemented or that you want to see changed that will benefit either your own career as a GP and the stability of that position, or the care that you can provide your patients?
I might take that one first, but I'm also going to ask our Chief GP, Mel, as well. For me, one of the greatest policies that I would like to see changed is investment in long care. For so long, Medicare has really rewarded short turnover. The most profitable way to be a GP is to practice 6-minute medicine or to value yourself and privately charge. And what patients need is actually management of the complexity that they present with that opportunity to address, 6 or 7 things in that single consult. So look at their immunisations, look at their changes in family history, explore where their health behaviours are up to, make sure all of their screening is up to date, and that just takes time. And it takes time and trust. And when someone trusts you and you spend time with them, you can often understand what's happening within their health behaviours. That's probably the biggest one on my list at the moment, but I'm going to give Mel an opportunity as well.
See, I realise I go to the legislation that I want changed, like the 19.2 rule for Medicare, which is in the Health Insurance Act, which is where it says that you can't charge Medicare if you're getting money from somewhere else. So that is why you can't bulk bill an appointment and get an out-of-pocket expense when you see a GP. It's not just in seeing a GP, but you can't, but it also means the state government or the jurisdiction can't pay alongside a Medicare billing. So it just causes a lot of challenges, and this is where actually just having one health system, not a federation, the federal level and then the jurisdiction, and we're splitting who's responsible for what, and there's the National Health Reform Agreement about what the federal government pays for and what the jurisdictions are responsible for. If we could get rid of that, it would help a lot.
Yeah, so Dr Dorrington just advocated for dismantling the Federation right next to New Parliament House.
They're just changing where health lies.
You didn't laugh at that. I really hope you've attended your civics classes in high school so that you understand what I'm talking about. Fantastic question. And look, the part of it is opening your eyes to where things can change. And policies happen at all levels of government. But I really maintain that the level of government which has the capacity to do the most harm is the most local. So we have a job to advocate locally for all of our patients so that they can access high quality, affordable healthcare. But just never forget that the Medicare rebate is the patient's rebate. So that's what they get back in their pocket after they spend on health. And it's not up to us to personally hold up the health system with our own charitable work. Next question. Claire. So Claire is an amazing, I'm going to give her a plug because she never plugs herself. Claire's an absolutely amazing resident medical officer who is also a member of the AMA ACT board, and she is a fearless advocate for junior doctors.
Thank you, very undeserved. My name's Claire Bannerman. I'm one of the JMOs at the Canberra Hospital. I know many of you in the room and looking forward to meeting others. At the moment, there's a lot of dialogue and advocacy for rural generalism as opposed to urban GP, and there's a lot of discussion about whether rural generalism will be set up as a bespoke specialisation, even more so than it is now. What are your thoughts or views about the benefits of looking at rural versus metropolitan GP, and will the shift towards having rural generalism as its own specialisation shape what we need to be doing to prepare ourselves to either become a rural generalist or an urban GP, whereas at the moment we sort of have a bit more flexibility to tailor our careers to get to that goal? Maybe more for Dr MacKinnon and Dr Agostino.
Yeah, cool. So I guess I'm a rural GP who doesn't see much distinction from myself to my urban GP counterparts, and I think it's because my focus has always been on primary care of the community rather than, I've never done a procedural subspecialty, so I'm not a GP anaesthetist or GP obstetrician. It was interesting, so I grew up doing GP training with the first bunch of rural generalists, and they're good mates of mine still, and our careers do look a bit different. Those guys are normally attached to a hospital because of where they're working, and they did find when they had to do primary care stuff that they struggled a little bit within the rural generalist model. They'd just be like, what's going on with all this screening stuff you're doing? So I guess the core question was, does it mean that we're having separate training things to be for rural GP and others? And I think it is not, because the diversity of what rural practice is broad. And there are really important skills that we need in rural communities that are focused on the primary care aspect, not this, the proceduralist components of it. And my understanding of where rural generalism wants to go about positioning itself separately, and I sit on the MBS Review Advisory Committee, so I get to have a say in decisions about this, is that really what we want is for rural generalists in the future to be able to access specialist items, because they're providing specialist services in communities. We don't think we need a separate item for generalists like us. So that's where we sit in.
Look, it's a difficult question. I'm a GP proceduralist, but I'm also a rural generalist. I mean, it's more sexy to say rural generalist. The thing is, with my anaesthetics, for instance, I couldn't really work in Sydney because they won't allow GP anaesthetists to work in Sydney. So you can only practice your procedural skill in an area where that can be provided, because there's the opportunity, the infrastructure, the facilities, the population to allow you to achieve that. Look, the reality is, if you are a passionate GP in an urban situation, you can do almost as much or as little as you want. You can refer everyone off to the cardiologist, or you could do your exercise stress tests, or you can access imaging, you can jump the hoops, you can do all those investigations and deliver that patient to that cardiologist with the diagnosis already made. Now, we do that in the country, but you can also do that kind of thing in the city, but it just means you have to, take ownership of the problem and follow it through and facilitate it and ensure that the patient accesses those investigations. I never send a patient to a surgeon without the diagnosis that they've got gallstones. So, we make the diagnosis before we send them to our specialist colleagues, partly because, coming to Canberra to see a cardiologist, for instance, is a 6-hour return journey for us. and you have to wait 3 months to get in, and then you have to go back after your investigations. So we facilitate all that. But the point about all of that is that it makes the work that we do as a general practitioner very rewarding and very satisfying, because it's real medicine. So I'm not just sloughing it off to the specialist because I can. And that depends on, the pressure of appointments and the availability of your specialist colleagues. But by doing what I can do in the country and you could do in the urban situation, you can, leapfrog some of those barriers for your patients. So it is difficult, but I think you can practice extraordinary medicine in the urban environment as well, but you have to forge, your pathways and your referral patterns and your own, practice.
It is way more fun when you get the letter back from the non-GP specialist that says, thank you for your very thorough workup and your existing management plan, and I have nothing to add. It's a lovely tick in the right direction. But it's exactly true. I think one of the questions that often comes up is, if I've got to start in urban GP because of family commitments or other matters, could I later go rural? And the answer is yes. You might have to spend a little bit of time investing in upskilling in the spaces where you feel like you're not as strong, but your career can start and end anywhere, and that's the beauty of general practice. There are more and more roles, even in urban centres these days, for what we call a GP with special interest. And we're having lots of discussions with different, both small and large hospitals, about where those spaces are for GPs. And there's lots of proposals that are coming out around GP anaesthetists coming back into the bigger hospitals. We've got a huge workforce issue and massive amounts of skills. So if you can, try. You won't always succeed. You can't have everything that you want in this world, unfortunately. We try. But if there's something that you're interested in, do some extra terms in that and upskill, and then find your place in the world, because doctors are needed everywhere. You just might have to be a little bit flexible about where you end up. Other questions? We've got about 8 minutes left, is that right? Or look at us go. All right. This is really your opportunity. There are no dumb questions. Ask everything that interests you.
Hello, my name's Jesse. I'm a third-year medical student at ANU. I'm currently in Cooma on long-term rural placement. My question is, it's sort of similar to the first question we had. I'm just wondering, in terms of bulk billing and private billing, where you really want that time to, give holistic quality care, but I've also got like a personal interest in bulk billing to, make care more accessible with my practice in the future. I'm just wondering how much room there is in bulk billing for that kind of holistic, longer time spent with patients, and if not, any advice around dealing with that compromise.
I'm gonna answer a little bit, and then I'm actually going to ask Mel to answer it, because she works with the deep end GPs. For me, one of the principles is that we do value things that we pay for and that we invest in. And I do work with a lot of very vulnerable patients. So I continue to look after patients after they're discharged from a residential facility called Carolika, where people go because they've got drug and alcohol issues. And essentially I negotiate with them, which is something that I learnt from John Deary. So Mel and John own a couple of practices here in Canberra. And John taught me the okay, right now you need it, but in the future, let's talk about what you need. So I might bulk bill my patients for 3 to 6 months while they're still looking for work after discharge and while they get back on their feet. But then they will come to me and say, hey, I've got a job now, I want to pay. And then we figure out how much of a gap can they afford. And people often surprise me about what they're willing to invest in their health. And you know what? I don't talk about how much I bulk bill publicly in the media, because it does create a sense of people missing out. but I don't charge my palliative patients, and I don't charge my home visits for my dying patients. And I still bulk bill all of my DVA patients, and I bulk bill those people who I know are working 2 jobs, both husband and wife, really struggling, not sure they're going to keep paying the mortgage. Yep, absolutely. So you can do that, but the other side of it is that I cannot be personally responsible for funding the health system anymore, because I too have a mortgage, and as a private billing GP, I am very satisfied with my income. I can pay my mortgage. I just bought my dog a new bed because that's, they're my priorities. Yeah. It's the can I afford the dog food? But if I go to 100% bulk billing, I can't afford to do that. So that's where the advocacy side and those conversations about, if you're going to make an election promise, you actually have to fund an election promise. And that's where we hold the government accountable. But yes, there are people who cannot afford healthcare, and we have to acknowledge that, and we have to support those people. So I'm going to ask Mel to also respond to that.
I think it's sort of from a socialist perspective, which is how I see myself. Absolutely, people shouldn't have to pay for what they need. Unfortunately, what people see is what they need isn't actually always what they need, and there is no other element in the support services that people can access for free. So, at the practice that I'm at that is bulk billing, I've actually recently decided, and I've not told many people, I'm actually moving on, because for my 1 day a week, I realise I'm not doing enough general medicine. And that has been a difficult realisation to come to, but because I have the same complex patients seeing me every 4 weeks, and they are long consultations, it has become, for 1 day a week, as my clinical work, quite draining. And I realised that for myself, I can't keep doing that. It's not my passion areas that I was talking about, and I realised that's what I need to get back to. So previously, I'd done sort of half and half, so worked at Woononga, where it is bulk billing, and worked in a private practice. Obviously Woononga's got a target population. Not everyone that goes there is Aboriginal. But I've also done a long time in private billing, and you do choose who you bulk bill. Choose, that makes it sound like a comment that I read the other day about it's the mood of the GP and the whim of the receptionist about it. It's not. I think most of us try to be more informed than that when we choose. But the cost to run a practice, so the amount that's being charged to Medicare, if you want to do 6-minute medicine, you can keep it up and you can pay for the cost of the practice. For the particularly vulnerable patients, it doesn't meet their needs. That clinic needs to be funded through another way to survive, because bulk billing doesn't actually support it, so that you can still pay your receptionist, pay your nurse, have all the equipment that you need. They're not paying for the dressings and the whatever else that's not covered. So there's a complexity there, plus the fact that if you talk to our psychologist and psychiatrist colleagues, they will comment that if someone isn't contributing something, they're not going to take away the same amount. And I certainly feel like there's a number of patients that I get quite frustrated with the number of times we have the same conversation, because they're not putting in anything into the consultation that we're having. They're not contributing anything. They can just come back and have the same conversation with me next week, and apart from their time, it makes no difference to them. Whereas it's taking away an appointment from someone else. So it has previously, which is typically the way that it works in most practices, the gap there, it might be more than what is required, but it's because you're actually making up the gap of those people that can't pay it. So they might be a bit better from the, the extra bulk billing incentive that everyone's going to get, but at the same time, they've not changed the base Medicare rate. And your long consultations are still being penalised compared to your short ones. So for vulnerable patients, what we need is actually more investment in the long appointments, and that people can see social workers and all that sort of stuff without, they're accessible, there's no financial penalty. social prescribing type stuff, link workers, all that sort of stuff, community stuff.
We talk a lot about the GP, but we are part of a team, and our receptionist staff have to be paid properly because otherwise they'll even go to the public service. Our nursing staff have to be paid properly because they work really hard. I'd give anything to have a social worker in the rooms with us, but we really are, we're part of a team, and we actually just have to be financially viable or general practices close. So, and that said, you know, I've done a lot of media this week about bulk billing, and consistently every single one of my patients who's raised the media at the end of their consult after I've pressed stop and I'm not charging Medicare anymore has said happy to pay. All right, we are out of time, and everyone's starting to wiggle a little bit, which means you probably all need a stretch. I would really like to say thank you so much for the incredible knowledge of the people who are on the panel today and the generosity of giving up their time to come and talk to us today. If you've been too shy to ask questions, please grab us throughout the day. And thank you so much for coming along to think about this as a career. And I will hand over to Adam.